Now, before we're going to inject her, we're actually going to now show you how to inject perfectly safely when considering vascular risks, and therefore where to and where not to inject, which is based on arterial foramina, the pathways where they're going from and to. And just to show you that sometimes you are in a much more dangerous position than you think you are, because you're only 1 millimeter away from disaster. For those of you that don't routinely inject the forehead, let's give you some reassurance. When I pinch the skin here, you can see the entrance of the supratrochlear artery into the forehead here. When I pinch in the midpupillary line, you can see that the supraorbital artery comes in here. Now, both of these vessels, when they enter the forehead, they're on the bone. As they ascend up through the forehead, the vessels become more superficial, and at the 2 centimeter junction above the supraorbital rim, those vessels are subcutaneous. So this is the line typically where we see a depth change, and a black, thank you. So when we're injecting above that line, what depth do we need to be? Deep, right? On the bone, and you've got no risk. If you go superficial here, you're going to have a big vascular risk. Let's have a look at the temple. Temple should be really easy and safe. So I'm going to demarcate the superior border of the temporal fossa, the anterior limit, and also the inferior margin, which is the zygomatic arch, and really the hairline, which demarcates the posterior border. Now, this is the aesthetic temple. The anatomical temple, it goes all the way back into the hairline, but we don't want to treat this bit, we want to go here. The temporal fossa is pretty much like this shape. It's like a free-form swimming pool. And you have a deep end and a shallow end. The muscle here is thick, the muscle here is thin. Therefore, there's more blood vessels here than there are here. And the key blood vessels, you have number 1 is superficial temporal artery, like so. Number 2 is the posterior deep temporal artery. And then you have the anterior deep temporal artery. Now, these 2 vessels run in the temporalis muscle. This one is running in the subq. What it means is that in this superior medial quadrant of the temporal fossa, you have complete safety right here on the bone with a needle. If you go superficial here, you may catch the frontal branch of the superficial temporal artery. If you go too far down, you may catch the deep temporal arteries, so just stay away from that. Now, what about the cheekbone? This is the inferior border of the zygoma and the superior limit of the zygomatic arch here. Remember I told you about this tiny little pinhole? I'm on it now, here we go. Which is the tiny zygomatic facial foramen. Now, this can cause a slight bruise if you catch it. So just be aware of that, and you can palpate it out on a lean patient. When dealing with the cheek, though, you have got the extension of the external carotid artery. It goes up like this, and it disappears behind the zygomatic arch, comes out as the superficial temporal. In the inferior border of the zygomatic arch, you have the transverse facial artery. What I'm saying to you guys is, when you're injecting here in V1, V2, it's completely safe. But if you miss the bone and you go above, you have danger. And if you miss the bone here and go below, you have danger. So basically, be on the bone for pure safety. When we're dealing with the medial cheek, I think we talked about the midpupillary line. I mean, it's really the medial limbic line, which is the dangerous territory. Eyes up, please. So I'm going to mark out, first of all, the infraorbital rim. Then the lid cheek junction, right here. And 1 centimeter below the infraorbital rim, this is the midpupillary line. This is the medial limbic line. It's the inner aspect of the pupil. So mid-pupillary, medial limbic. You see the difference? There's about 2 millimeters in it. So if I draw a vertical line down like this, to 1 centimeter below, and put in the infraorbital foramen like so, but also mark out where the danger zone is. And we're going to essentially declare this as a no-go region. You can't be injecting with a needle around here. So if you have a hollowing here, what mechanism should you be using to get there? A cannula, right? So you see, I'm not against cannulas. I think there's a time and a place for all that stuff. So essentially, when we're doing V3, make sure that you're injecting lateral to the mid-pupil line on the bone, and you're 100% safe. There's no artery right there. Now let's have a look at nasolabial fold. The facial artery, it enters the face here at the premasseteric notch. And as it coils its way to the oral commissure like so, and then it comes up lateral to the buccal maxillary ligament, and then becomes the angular artery. The ligament is lying just medial to that artery, which means that if you breach the line of the fold and you go lateral, you've got a vascular risk. So therefore, we are going to inject Lizzie medial to the ligament onto the bone, injecting perpendicularly away from the artery as to not follow the artery, because if we follow the artery like this, you've got a much higher chance of being inside it. When we do her lips, we are going to do a safe injection which is above the level of the superior and inferior labial arteries. Now, those arteries are running underneath the orbicularis oris muscle. So when we're doing her lip, here and here, this depth of this injection must be subcutaneous or submucosal. If you go through the muscle here, you've got a vascular risk and you may have an occlusion, you certainly have a bruise, ecchymosis, or even hematoma. Let's have a look now at her jaw and chin. The marginal mandibular branch of the facial artery runs in the submandibular groove like this. So when we're injecting here the marionette line, like so, we're injecting and staying medial to the mandibular retaining ligament. This injection here must be in this orientation, never coming from below, because you're going to skewer the artery on the way in. When you're injecting this one, you've got to take care of mental foramen. So therefore, if it's in the same territory as the mental foramen, don't inject on the bone, inject under the muscle instead. When we're injecting the oral commissure, we need to keep it in the subq, so over the top of the orbicularis oris muscle, as to not prang the inferior labial artery. The midline of the chin is actually exceptionally safe. I mean, there's just no vessel there, but you want to try and place the product between the two bellies of the mentalis muscle really for accurate delivery. Now, we're going to just finish off here by looking at this region here, so the angle of the mandible. Now, typically in this area, you've got quite a few issues. So we've got the ramus of the mandibles like this. If you miss this bone and you go here, and you inject into this external carotid artery with enough pressure, and the product goes down like this, and it goes into the internal carotid system, that's not good, because this is where patients have had strokes and all sorts of stuff. Don't worry about it, Liz. It's not going to happen to you. So the other thing in this region is when we're injecting on the angle is, if you pass me a green, please, thank you. We've got this structure. What is it, everybody? It's a gland, parotid gland. So The parotid gland is typically in the intermediate level. Means if you're in the skin or you're on the bone here, there's no risk. But if you go in between the two, you're going to have a problem. Take a blue now, thanks. Now, in the inferior level of the tragus, you have here the facial nerve. Look at this. 5 branches, all of which are embedded within the body of the parotid. And therefore, if you're using a needle in this area, you're going to have a problem. Because if you transect that facial nerve, you're going to cut the motor supply to the face, and you're going to have a patient who's got a facial hemipalsy. And those hemipalsies, they tend to be permanent. So you don't want that against your name and your career. So therefore, what would I suggest if you were going to inject here into the subzygomatic region, technique-wise? Cannula, right? So cannula is the go-to intervention for that region. You know, when we inject, there's only 1 millimeter sometimes between safety and danger. 1 millimeter depth, safety and danger. 1 millimeter depth, safety and danger. Also, not too far away here from being dangerous territory. So think about your orientation, think about your depths, think about the product selection, and think about the volumes, because to stay safe, you need to consider all of those things, and really to get a 10 out of 10 result, we need to be delivering a 10 out of 10 exquisitely on the point, accurate and precise intervention.